Welcome to the First Principles of Medicine podcast. In this series, we will be breaking down complex medical topics into their first principles. When the stress is on and you've just been asked a tough question that you don't know the answer to, we feel you'll be able to fall back on these principles to formulate a decent answer and perhaps reason your way out of trouble. On today's episode of 1PM, our resident cardiologist, Jason, will be talking to us about the management of heart failure. Take it away, Jason.
Okay, hi everyone. My name's Jason and today we'll be discussing management of heart failure. So, we'll first go through how it's classified. What are the two main classifications of heart failure based off ejection fraction?
Preserved ejection and reduced ejection.
Yeah. So what does preserved ejection fraction even mean?
That the ejection fraction is more than 50% in preserved and reduced is less than 50%.
Yeah, so usually the preserved ejection fraction means that the ejection fraction is greater than 50% and the reduced one is less than 40%, okay?
Oh, 40, not 50.
Yeah, 40.
Oh, okay.
What happens with that 10%?
Yeah.
in
Maintained
between.
ejection
I have
fraction.
no idea.
Yeah, because there's no third class. I really want to talk about this 10%. Why is there 10% missing?
Okay, so just clarify.
Jason's wrong.
Just clarify.
Okay, okay.
I think in the lecture slides, it does say that 10% is, they just don't talk about it. like what?
All of you shut up. Okay. To begin with, in a clinical environment, usually heart failure is broken down into two different types based on the ejection fraction.
Okay.
And can someone explain to me how is ejection fraction calculated?
The end
Systolic?
systolic volume. It's the end diastolic volume minus end systolic volume.
Yeah.
Right?
Or like a proportion of that, yeah.
Yeah.
So what actually is the end diastolic volume?
So the end diastolic volume is the amount of blood in the heart or in the left ventricle at the end of diastole, at the end of filling.
Yeah, and what's the end systolic volume?
So the end systolic volume is the amount of blood left over in the heart after systole, after contraction.
So when we were talking just now, are we talking about the heart or the left ventricle? Because Dan was saying left ventricle.
So technically there's ejection fraction for the right and left side of the heart, but usually when someone's referring to ejection fraction, they're referring to the left heart specifically.
But if you think about it, they have to be the same, roughly the same. Because if one is pumping more blood than the other, then blood is backing up somewhere else. So technically your left and right need to pump the same amount of blood. Do you know what I mean?
Really?
Because if your right heart is pumping 70 mils of blood to your lungs, and then your left heart's only pumping 30 mils of blood, where's that difference in blood going?
No, I don't think that's right.
Isn't there more blood that goes to your left side of your entire body compared to the blood that goes to the lungs?
No, it's the pressures that's different. It's not the volumes.
Oh, really?
As in, what do you mean volumes through the heart? I know that the venous circulation has like 4/5 of the volume, right?
Oh, okay.
At rest, and the pressure in the arterial circulation is higher, but it's got less volume in there.
But this amount of blood is the same in the left ventricle and right ventricle.
Right?
So you're trying to say that the left and right ventricle pump the same volume, and I get what you mean, because if there's less in the right ventricle, then how does all the blood get oxygenated? Like how is enough?
Yeah.
How is there enough oxygenated blood in order for the left ventricle to pump?
Yeah, that makes sense. Cardiac output, heart rate times stroke volume. The stroke volume, the amount of blood.
Because your left and right ventricle pump at the same time, right? Roughly the same.
So the chamber volume is the same, but the left ventricle has just thicker muscle.
Yeah, because the pressures are different. Because your left ventricle is pumping against aortic pressure, but your right ventricle is pumping against the much lower pressure in your pulmonary artery, right?
Yeah,
really? That's just weird to think. I thought there's more space in your brain, your feet, and whatever, and then there's only that small space in your lungs. But that's probably my misunderstanding.
No, you're right. There's more space in your body, but as to how much blood gets through the heart per beat has to be the same.
Yeah, okay. I can understand that. I can know that.
Yeah.
Well, I can think in the inverse. The left heart cannot pump more blood than the right heart, because where's that blood come from?
Yeah, exactly.
Okay,
yeah,
okay.
Well, anyway, sorry for that tangent. But going back to JT's point, when people refer to ejection fraction, they're usually referring to the ejection fraction of the left ventricle. Okay?
Sure.
And does anyone know what the usual or what the normal person's ejection fraction is, percentage-wise?
Normal is 50 to 75.
Yeah. So you don't really get like 90%.
Yeah.
Okay, so first heart failure with reduced ejection fraction is classified by two things. Do you know what those two things are?
No.
Is it like reduced ejection fraction, so less than 40%, and I don't know, signs and symptoms of actual heart failure?
Exactly.
So reduced metabolic
Okay. So symptomatic and non-symptomatic.
Yeah.
So symptoms and signs and a left ventricular ejection fraction less than 40%
Okay.
are the two main criteria needed to fulfill heart failure with reduced ejection fraction.
Okay. So just to clarify, if you have a reduced ejection fraction in terms of the number, but you're not symptomatic, then technically you don't have heart failure.
Yeah.
Okay, gotcha.
Okay.
Sure.
And now for heart failure with preserved ejection fraction, does anyone know what the criteria are? There are like three basic ones.
Would it be the preserved ejection fraction but symptomatic?
Yep. So signs and symptoms is one. The left ventricular ejection fraction has to be greater than what?
50%.
50 to 60?
Oh, it has to be greater than 50%.
50%.
Okay. And there's another criteria which is different to heart failure with the reduced ejection fraction. Okay. Does anyone know?
Are we talking about like hypertrophy or something like that?
So one of the criteria is structural changes compatible with increased left ventricular filling, like left ventricular hypertrophy or left atrial enlargement. So that's a sign.
Okay.
Or there could be signs of something else. Diastolic dysfunction. Okay. As well, with preserved ejection fraction, you also get elevated levels of natriuretic peptides.
Natriuretic.
Yeah,
peptide.
I think like BNP and stuff.
Yeah.
Because can you imagine, you do an echo on someone, their ejection fraction is normal, they're symptomatic, so how can you confirm they've got heart failure with preserved ejection fraction? You need to look for some other signs.
Right, okay.
So the reason why I've gone through all this rigmarole is that heart failure with reduced ejection fraction is managed a lot differently to heart failure with preserved ejection fraction.
Okay.
So I'm going to ask you a question now.
Wait, so if we were talking about those two different categories, so for the reduced ejection fraction, there is no structural change needed to classify as reduced?
Yes.
Whereas
You just need the ejection fraction less than 40% and signs and symptoms.
Can there usually be structural changes that you can
They
see?
can be, but once again, it's not essential to meet the criteria for reduced ejection
I wonder why,
fraction.
but cool.
Oh my God, such a long word to say every time. Heart failure with a reduced ejection fraction.
Did they say REF?
REF, yeah.
REF? Okay, maybe you can
REF
say
and
that.
PEF?
Yeah.
Is that what they say?
Okay, so starting off with heart failure with preserved ejection fraction, how is that managed? Are there prognostic medication available, or is there only symptomatic treatment available?
Okay, so just to confirm, when you say prognostic, describe what you mean by prognostic.
Okay, so what I mean by prognostic is that it helps to reduce the...
Would you say it improves the prognosis?
Yeah.
Okay.
It improves the prognosis of the disease.
Okay.
It doesn't just help to relieve symptoms. Yeah, so help improve like longevity and things like that.
Cool.
Whereas symptomatic medication just make you feel better.
Yeah.
But it doesn't really help reduce the progression of the disease.
Sure.
So basically, heart failure with preserved ejection fraction, okay, there's only really symptomatic treatment available.
Okay.
There's nothing which improves the prognosis. It's mainly only symptomatic treatment. Okay? And now for heart failure with reduced ejection fraction, is there prognostic medication?
There's both.
Or symptomatic?
I'll stop you there. There's both.
Yeah.
Yeah, there you go. Sorted.
And is this because there are structural changes?
I have no idea.
Maybe the damage is done because you already got structural changes?
As in you can't reverse those cardiac remodeling?
Maybe.
With the dilated ventricles or whatever?
Or the hypertrophic ventricles.
Yeah.
I'm just trying to use the first principles.
Yeah, I assume if that is the key difference and one is prognostically different, that might be why.
I don't know what the reasons are, but all I just wanted to demonstrate was that heart failure with preserved ejection fraction only has symptomatic treatment, whereas heart failure with reduced ejection fraction has symptomatic and prognostic treatment. Then I assume it's very multifactorial as to the reasons why.
Sure.
Okay. But now we're going to get to the fun part. This is the main part of the presentation today. So for management of heart failure with reduced ejection fraction, we've got the medical, non-medical and interventional sides of management. So we're going to start off with the medical management first. So this can be quite confusing when you first research about this because it's usually a diagram with a huge flow chart but I've tried to break it down very simply. So basically, there are 5 main prognostic medications. Does anyone want to spitball what one of them could be?
ACE inhibitors?
Yeah, that's one. JT, what about you?
ARBs, do they count as the same class as ACE inhibitors?
Yeah, I'll count them same. So we've got ACE inhibitors or ARBs.
Beta blockers?
Yeah, beta blockers one.
Diuretics?
So diuretics is technically not a prognostic medication. It's the primary symptomatic medication. Okay?
GTN?
No.
I'm guessing no.
Are these medications that we've heard of before?
Yeah.
Okay.
The reason why I'm asking this because when I was on a cardiology ward, they were like, what are the prognostic medications for heart failure?
MRAs?
And I said diuretics, and they're like, no, that's symptomatic.
Ah.
So?
MRAs?
Yeah, what do you mean by MRA?
Mineral corticoid antagonist?
Yep, you're right. So you've got
spironolactone? Is that one of them?
yeah, that's
okay.
a name for it. So we've got ACE inhibitors, beta blockers, and mineralocorticoid receptor antagonists.
Right. Cool.
Okay, we've
Wow,
got 2 more.
2 more.
SGLT2 inhibitors?
Yeah, that's
Really?
one.
Is that for diabetes?
We'll go into that, I'm
We'll
sure.
go into that. Yeah.
And there's one last one.
Give me a clue.
It's related to the ACE. It's related to the RAS system, and it's kind of a newish drug.
Give us another clue.
It's probably it uses.
What does it rhyme with?
It uses a okay. It's actually like a combination of 2 different drugs. One part of the drug is an ARB, and the other one is a totally different mechanism.
Is this? We've seen this before. We know.
You may if
I don't think I've
in
seen
the
it.
hospital. It's quite like you
What's
do
the
see it.
suffix?
Well, you probably never heard of it, but it's called an angiotensin receptor nephrolysin inhibitor.
That's definitely something I've not heard of
Yeah,
before.
no.
It's
Nephronizing.
under the name Entresto.
Nah.
Surely you've never heard of Entresto.
Oh, I'm sorry. Yeah.
Hey man, we haven't been on the card.
Yeah.
Anyway,
Alright,
so this is like a new generation drug.
These are
basically.
5 classes of drugs, to recap?
Yeah.
Okay, so,
Okay.
So these
ACE
are-
ARB, and then that special ARB, and then beta blocker, the SGLT2 thing,
Inhibitors.
and
MRAs?
MRAs.
Yeah.
Okay.
And just to clarify with the MRAs, they are sometimes called potassium-sparing diuretics.
Yeah.
Yeah, okay. All right.
Anyway, I
We'll
just
stick to
wanted.
that, yeah.
I know. Yeah.
Because spironolactone is a diuretic.
We haven't
Yeah.
gone through what each one of them do,
Go.
but I just wanted to reiterate that those are the 5 main prognostic
Yeah.
medications because
Yeah.
they'll make your life so much easier when trying to understand how to manage.
I'm just going to
heart
go for
failure.
3. I'm just going to remember 3. I'm not going to remember 2 of them, I swear.
It's the special ARB.
There's a special ARB and MRAs probably. I don't know. Or SGLT.
And what was the special ARB called again?
Entrestin? or the-
Entresto.
Entresto.
And
So it's
angiotensin
this is the
receptor
nephronizing.
Yeah, it's a combination of sacubitril and valsartan.
Shut up. Just
Yeah.
shut up. This is not first principles crap, man.
All
This
right.
this is really not first principle, but this is more like
Not
if
really.
you just remember these 5 drugs, man, for heart
Dude,
failure.
you can
come
say
on.
that for every condition. Just remember these.
This is heart failure we're talking about.
Okay.
It's everywhere.
Okay, but like, I'm pretty sure that in a consultant ward round, if you remember 3, it's probably okay, right? Like, if I don't remember Entresto, I'm okay with that, I think.
No, just remember.
Just remember Entresto.
But anyway, now that we've gone through those 5 medications, it's probably good to actually understand the first principles, JT,
Yeah.
as he keeps reminding me.
Yeah, sounds
Okay,
good.
so let's go through the first one, ACE inhibitor. How does it actually work?
Just messes with the RAS system. That's about it.
Yeah, come on, but like, where does it act? What is ACE? What does ACE even stand for?
Angiotensin converting enzyme. 1, 2. There's 2.
No,
There's just,
no,
there's just-
you don't even know what ACE is.
It's just okay.
No,
But
yeah,
there's angiotensin 1 and angiotensin 2.
yeah.
Okay, all right.
But ACE inhibitor, you forgot that part.
Yeah, sure. Okay, yeah.
Okay,
Yeah, the
so-
small I, yeah.
Small I.
The small
The I is important because otherwise it's just the enzyme. You need the inhibitor.
Yep.
And these are the prils, right?
Yes.
Yeah. Okay.
Yeah, so ACE inhibitors end in prils, and they inhibit angiotensin converting enzyme, which is important in converting angiotensin 1 to angiotensin 2.
Mm-hmm.
And why would that be important for heart failure management?
So the
Renin.
renin-angiotensin-aldosterone system is involved in basically retaining salt, retaining water, which will increase blood volume, increase blood pressure, which is not good for a failing heart, to put it simply.
So that decreases preload and or afterload, or is
So
it?
what JT just mentioned there, basically, from my understanding, ACE inhibitors help to reduce the preload and reduce the afterload, which makes it easy for the heart to function.
Yeah, okay. Yeah. So this is mainly fluid load that we're talking
I guess
about,
so,
yeah?
Yeah.
Fluid volume.
Yeah.
Okay. Now let's go on to beta blockers. What type of beta blockers first do you want to use?
Selectivity.
Oh,
Yes.
the heart
Cardioselective.
specific.
Make sure you say
Yeah,
cardioselective.
cardioselective, yeah.
Okay.
Yeah.
Okay. And it's important to specify that it's cardioselective. For medical school, it's just easy. Just remember one example.
Okay.
So one example of that is bisoprolol.
Yeah.
It ends in olo.
Yeah.
Yep. So that's cardioselective beta blocker. And
Yeah.
why would you use that?
Because you want to affect the heart, not the other stuff that.
Yeah. But
Yeah.
why a beta blocker in general?
As in, how does a beta blocker work?
Yeah.
To reduce heart rate and contractility,
Yeah. So why do you want to reduce heart rate and contractility?
because you don't want the heart to overwork.
Yeah.
Reduce
As
the
in-
work of the
yeah,
heart.
reduce the work
Yeah.
of the heart.
Yeah, but and what's the main issue with the heart working a lot?
If it's working too hard, you're how do I phrase this? Having a
Increases.
bigger metabolic deficit.
No. This is one word. Why use beta blockers for? It's to help prevent cardiac.
Remodeling.
Let me explain. So with the heart failure, so your heart's it's failing, right? It's not working well. Okay, so there are a lot of signals to try to kick it up its ass to get it to work a lot, and with those signals, which get it to work harder and harder, that can lead to cardiac remodeling or hypertrophy. Okay. So next one is mineralocorticoid receptor antagonists. What do they do?
Antagonize the mineralocorticoid receptor,
Yeah, and what is that receptor?
aldosterone receptor.
Yeah, and
And
And that
spironolactone.
reabsorbs water.
I think it's a sodium potassium
Yeah.
ATPase on the basolateral membrane of
Shut the
the
fuck
cells
up.
of the distal tubule.
So
this guy didn't even know what cardiac remodeling is, and he's fucking trying to give me a lecture.
remodeling is.
So it reduces fluid retention, does it not?
Yes.
Yeah.
Reduces sodium retention and then fluid retention.
Just think about
Yes.
it.
Yes.
Think of it simply. It works
I
in
have
the RAS
figures.
system. Okay, it helps to reduce fluid overload, things like that. Okay.
Because it works on the sodium channel.
Yeah.
Yeah, but fucking like just.
Isn't that what you're asking? The aldosterone is the sodium and whatever.
Aldosterone is the sodium.
Is aldosterone responsible for the sodium potassium
Yeah.
channel?
Yeah.
So less sodium into the water follows sodium. So
Yes.
less reabsorption means more excretion.
Yeah.
And then does that downstream affect less afterload or less fluid?
Yeah.
Yeah.
It's a
then
diuretic, so you get rid of
pretty
more
much
water.
So then less afterload, easier for the heart.
You mentioned before that diuretics are not prognostic, but here we have a diuretic that is prognostic.
It's confusing because all the websites say that diuretics are only symptomatic.
Sure.
Only. But I swear from a lecture I remember listening to is that diuretics are so commonly used that they can't really do a trial ethically to assess whether it's prognostic or not.
Because it can't take it away from someone.
Yeah, because imagine if someone comes in with really bad congestive heart failure, it's pretty hard to do a trial trying to take away diuretics
Sure.
from them.
Hang on a moment. Spironolactone's a diuretic, right? And it's on the list for like
No,
improving
but it's
not
not
osmosis
special
medication.
diuretic.
No, but
right?
Yeah, but it's still a diuretic.
Because it's
It's not
potassium
considered-
sparing, though.
a potassium-sparing
No,
diuretic.
I know.
No,
I
so I
agree.
guess we can say that the symptom one is the loop diuretics.
Yeah.
Yeah, sorry.
Yeah.
To be
So
more
that's-
specific.
Okay.
Yeah.
So not all diuretics.
Okay.
So I kind of
No,
didn't
yeah.
think of spironolactone as a diuretic.
Yeah,
I
yeah,
thought
yeah.
of it
Sure.
more as a separate, more of a RAS
I mean,
kind of system thing.
It's okay.
You know,
Yeah,
because
just-
you weren't thinking of the first principles, Jake.
When I was thinking of diuretic, I was thinking more of furosemide, things like that.
Yeah.
No one says spironolactone as a diuretic, do they?
Everybody does.
Do they say?
Yeah, literally.
Oh,
I-
maybe-
see,
oh,
I-
fuck's sake.
It was
I-
taught to us that
See,
way.
I knew spironolactone as a diuretic, not as a mineralocorticoid
No,
receptor
I
antagonist.
kind of thought it as part of more of the RAS system, not really as a
you're,
diuretic.
you're talking about the loop diuretics.
Yes.
So you're talking about that's why you're in your head.
Yeah,
Loop diuretic.
so-
Not,
And the hydrochlorothiazides diuretics as well.
Yeah.
Cool.
Cool. We all good with that? Just
okay. So just to
Don't
clarify.
need to bully me.
So just to clarify, the diuretics that are not prognostically good, those are the thiazides and the loops. diuretics?
Just, yeah.
Okay, we're done. Okay, continue, Jason.
Yeah, man, and now I feel like an idiot. I never thought in my mind that spironolactone and mineralic corticoid receptor antagonists were like diuretics. I kind of thought of them as like RAS kind of stuff, not...
They should have just named it aldosterone antagonist.
You could just say that. That probably makes a bit more.
Okay, so moving on. Okay. We're done with diuretics.
And then it works on the rest?
We're done with diuretics.
Next one, SGLT2 inhibitors. How do they work?
I don't know. Fucking diabetes.
Right.
Oh, wait.
Yeah,
actually, I do know.
Mr. Basolateral membrane. Come on.
Go. Actually, well, from my understanding of diabetes, SGLT2 is a transporter, I think, in the kidneys, and it's an inhibitor with the small I, so it inhibits the glucose reabsorption into the body. So then I guess water also follows the glucose, and in a way, is it a diuretic then as well?
Yeah, you guys think everything's fucking diuretic now.
It wasn't presented to us in our lectures as a diuretic, though.
It's not diuretic.
Sorry, Dan, it wasn't presented in
but
your
that's
lectures.
an osmotic diuresis. That effect is osmotic diuresis.
But it's not working on the water. It's working on the glucose.
Yeah.
No, but nothing works on the water. It works on the salts.
Yeah.
So no diuretics work on the water directly.
Do you know what's confusing is that even though this podcast is called First Principles Medicine, sometimes we just don't know.
Wait, so you're telling me that when you said no diuretics, these are all diuretics?
You don't be like, I'm going to put this guy in SGLT2 because they're fluid overloaded.
These are the
no one says that.
You're very right. Yeah. You're very true.
Guys.
Yeah. But when we take it to
what did you say there, JT?
SGLT2 is they end in gliflozin. That's the suffix, and they inhibit the small I, inhibit the glucose, and therefore, by the mechanisms of osmotic diuresis, the water follows out of the body.
Yeah.
So we're talking about reduced ejection fraction now, right? Doesn't empagliflozin also help? Well, there's some recent studies talking about it helping with preserved ejection fraction.
Dude, does anyone actually look at articles? Why are you complicating this?
No. Because on internal med, I had a consultant who kept talking about this.
Dan, there's always technicalities. I'm trying to break it down so my monkey brain and the monkey brains of all these medical students can remember 5 simple medications for heart failure, so you won't get roasted in front of a cardiologist. Okay, 5. That's all.
So what's the one drug that's this SGLT2? Because we can't say SGLT2, can we?
Yeah, you mentioned it.
I didn't. I just know that suffix.
No, dapagliflozin.
I didn't say that. Dan did. I just know the suffix.
What is it called?
I said empagliflozin, but dapagliflozin.
Yeah. But are they all, as in you can use any of the flozins?
Well, I fucking don't know the difference between each. Do I look like a cardiologist, right? Do you think I know the technical differences between each type?
Okay.
Like,
so
come on, man.
End of
you
the
expect
day,
too much.
If I go and see a patient with heart failure, I look in the med chart. If I see a gliflozin, I'll be like, yeah, it makes sense. Okay, that's it. Cool. Be good.
Sorry, I haven't kept up to date with the recent research. Jesus Christ. And the last one is the angiotensin receptor nephrolysin inhibitor.
Fuck this.
Okay. AKA Entresto, because I never remember the other one.
Entresto,
okay?
I'm not interested in this one.
Okay?
Yeah, okay, good.
Yeah.
Good memory tricks. Entresto.
Yeah.
So that's a combination of sacubitril. Somebody, I probably absolutely butchered that. That's the nephrolysin thingamajiggy.
Nephrolysin.
How do you spell that?
Dude, I fucking...
So
what's its mechanism?
Is kidney...
but lysing's like...
I'm
split the kidney.
I'm quite sure. Let me look it up.
Well, yeah, so what is its mechanism?
The
I'm sure it doesn't
out.
do that.
The water's coming out.
Diuretic.
Basically, wait. So apparently they work by blocking the action of nephrolysin, thus preventing the breakdown of natriuretic peptides.
Okay.
But anyway, that in combination with an ARB is Entresto.
So, Entresto.
Yeah.
Would someone be on an ARB separate?
I'll go through how you actually like the formula to.
Okay.
I'll go through that.
And just remind me on what a natriuretic peptide does.
So, in heart failure, things like BNP and pro-NT-BNP are raised when the left ventricle stretches a lot, and they help to reduce. Wait, no. What is BNP? Wait.
Brain natriuretic peptide, right?
Yeah, what does it actually do?
I know it's indicated in fluid overload.
Mm.
So you can have it in kidney failure. You can also have it in heart failure.
So I've forgotten what BNP does.
So BNP is a hormone secreted by cardiomyocytes in response to stretching caused by increased ventricular blood volume.
Yeah. So what, it increases contractility or something?
No, it's a
leakage.
Natriuresis. Oh,
treated in response to it.
So what increases fluid output?
You know, it's one of those drugs where
Dilates the afferent glomerular arteriole.
Okay, increases GFR.
Increased GFR.
to be honest,
So it does increase fluid output, but it's not a diuretic.
to be honest, it's one of those drugs I can't be bothered remembering.
It
the
decreases
mechanism.
sodium reabsorption, so it is a diuretic.
Do you know what
What is
pisses?
defined as a diuretic? Does it have to be something like you measure your urine output every hour, or does it have to be more than
Oh, man, I don't know.
It's probably just...
Man, you chose a good topic.
You know, with these drugs, man, I'm sorry to say, like, do we actually know exactly how they all work?
Yes, we do.
entirely?
No, but some
people do.
We
people
do. We
yeah.
do.
Yeah, I
'cause-
want to spend 3 hours looking up intense.
No, we weren't. We're just seeing how it helps with the fluid load.
Anyway.
Just
So,
remember this
4
one
out of
drug.
5 drugs
Just
help with
remember
fluid load.
Entresto. Okay, that's all.
Okay.
You know, keep it simple. Just 5 things, okay, guys? That's all I'm asking for. 5 things right now.
Okay.
Okay. Now that we've gone through that way in depth, okay. So, now that we know the 5 drugs,
Yeah.
which has been made extremely complicated by JT, we're going to go through what I call like the medication selection algorithm. Okay.
Yeah.
So let's say a person comes in with heart failure,
Yeah.
which is a bit decompensated, they're a bit fluid overloaded.
Yeah.
Okay. Things
This
like
is
that.
reduced, right?
Yeah.
Reduced ejection? REF? Or
Yeah, we're with REF. So I've been talking about REF this whole time because, once again, PEF is only managed for symptomatic.
Yeah. Okay.
Hey, Dan, I swear to God, if you try it. Okay, so we're going to go through now the medication selection algorithm. Okay,
Yeah.
so patient comes in, they're short of breath, they're fluid overloaded. Do you think they're in heart failure? Okay?
Yeah. Okay.
What do you treat the symptoms with initially?
Diuretic.
Diuretic,
Yeah.
right?
Yeah.
And what's the purpose of that?
loop diuretic.
Specifically, furosemide.
Yeah, usually, like in my head, when I think of diuretic, I think of
I don't know, but
furosemide.
this whole podcast,
Yeah.
we need to be specific about diuretics. Furosemide, we give them.
Yeah. Okay. And then you add on 2
Mm.
other prognostic drugs.
Mm.
What are they?
The ACE inhibitor
Yeah.
or ARB.
Yeah, but ACE inhibitor. Yeah.
Sure. Okay.
And the other one,
Beta blocker.
beta blocker. Okay.
Especially the one with the B. No.
Bisoprolol.
That's just a
Bisoprolol.
name for a cardioselective one. Okay. So now that you've done that, okay, the way that it usually goes about is that you're giving them diuretics, you're giving them the ACE inhibitors and beta blockers. You then reassess, and then you have to kind of decide whether they need other prognostic medication, and that's usually based on 2 things.
Mhm.
Does anyone know what they are?
As a guess, their response to the initial 3 drugs.
Yeah. So how would you determine their
So if
response?
they're still fluid overloaded, if they still have pitting edema,
Yeah.
if they still have APO.
Yeah, so simple. So whether they're still symptomatic,
Mm-hmm.
and there's a second thing.
Would it be the ejection fraction?
Yes.
Yeah, because if you do the ejection fraction, it turns out they are preserved. Then you're not going to give them prognostic medication.
Yeah,
Oh,
because
what?
you're just trying to decide whether you need to give them more, right?
Yeah.
So if they're still symptomatic and their left ventricular
Yeah.
ejection fraction is less than 35%,
35%.
okay? So if those 2 things are indicated, then you go into adding on the other therapy. And what are the other 3 drugs?
JT, let's go.
I'm not interested. Entresto, baby.
Yeah. Wait, before Entresto, just go to the other 2. No, because I'll explain to you the other 2.
MRA.
Dapagliflozin.
Yeah.
SGLT2 inhibitor. The special diuretic, the MRA.
Yeah.
The Spiro.
Yeah, and last one you mentioned was Entresto. So basically what happens with Entresto is that kind of replaces the ACE inhibitor or the ARB,
Mm-hmm.
but because it's a relatively new drug, my understanding is that you have to first prove that the management has kind of failed with ACE inhibitor.
Right.
So then you can be qualified to give Entresto.
Okay.
So it's not covered on the PBS otherwise.
I'm not
unless
sure.
they've trialed
Yeah.
ACE or ARBs.
So
Yeah.
so you need to
Okay.
hit the PBS criteria
Yeah.
for
Yeah.
Entresto. So that's an important thing to note down. Okay. So whilst I gave the therapeutic algorithm, in reality, sometimes you have patients come in with like left ejection fraction less than like 15%,
Right.
10 to 15%. And it's not like you just start them on the ACE inhibitor and beta blocker and then you wait and see. Usually you kind of just chuck all 5 or 4
Right.
at the same time and just kind of monitor and make sure they're stable. So it usually involves a bit of playing around with the doses, playing around, like seeing whether they have any side effects, maybe starting one at a time or slowly adding all of them. So do you guys know what I mean by that?
Yeah, makes sense. Yeah.
Makes sense.
But you still got to wait for the Entresto.
Yeah.
Right? You can't.
Yeah. So
Or do people...
basically the caveat I wanted to give was that with Entresto, you have to meet certain criteria in order to prescribe that because it's a relatively new drug.
Sure.
And no one knows how it works. Or I don't know how it works. Neprilysin inhibitor. I don't know what the fuck that is. Anyway. Okay.
Cool.
And can we just with the drugs, are there any risks to giving any of the drugs?
Of course.
Of course. But
as
you know
in terms of if they've got decompensated heart failure.
Beta blocker.
Yeah, beta blockers.
Yeah, so beta blockers, you want to make sure they're stable before giving it to them. Aldosterone antagonist, whatever. You have to be careful of high potassium, SGLT2 inhibitors. If they're diabetic, you can get euglycemic ketoacidosis. But you know what? Those are all things everyone can look up. But yeah, those
probably pretty important, but sure. Yeah.
Yeah, pretty important. But do we have like freaking 2 hours to go through this?
Okay, yeah. Because go.
No. I'm just preparing you guys so that when the consultant asks you what medication, what are the 5 prognostic medication? They love saying prognostic. Okay.
I remember I was actually asked last year, beta blockers, yes, but if someone's like just come in, still fluid overloaded, if you give them beta blockers, you make it worse. So you got to wait until they're stable first.
Yeah. So I should have emphasized that more. But usually when you get... Yeah. So what Adian said was right. Yeah, the beta blockers, once they're stable, is very important.
But yeah, makes sense.
Okay. So now we'll go on quickly to the boring parts of medicine, the non-pharmacological management. There are 3 main things.
Let's go.
Should we guess or not guess?
Can you guys guess?
Go for it.
Fluid restriction?
Yes. And what are you usually, what's the standard kind of fluid restriction?
I've seen 1.5.
Yeah, 1.5 litre. Okay. And what's the rationale behind that?
To reduce their fluid intake.
Yeah, simple. Okay, next one.
Simple.
Salt restriction.
Yeah. And what are you aiming for usually?
2 grams. 3 grams.
I think less than 3 usually. And what's the rationale once again for reducing the salt?
Reducing fluid retention.
Yeah, because as you said, where salt is, that's where water kind of goes. Yeah. And last one. This one's the one you can't really guess.
This one, they took mine, but I don't know, like chest exercises.
Yeah, you know you're close.
Yeah, physio. Yeah.
It's called cardiopulmonary rehab.
Oh yeah, chest exercise.
Where it's
chest
pretty
physio.
much, from my understanding, it's where physios kind of get them
encourage
to exercise.
deep breathing. Yeah,
deep breathing.
Yeah.
I don't know if
And
it's deep
coughing.
breathing. I thought it was just like getting
Coughing.
exercise.
Show us what they do.
It's like the physicians always tell you, every hour take 10 deep breaths.
Is that for heart failure? I don't even know.
No,
I
it's
don't
for
know
heart
what
failure.
it was.
Yeah, it's for
I
heart failure
don't
as well.
actually know what cardiopulmonary rehab is. I just know.
I'm
know
sure
the
I'm sure it's
word.
much more involved than that. But that is
Deep breaths.
Yeah, like-
and that helps with what?
to open up the airflow, the air sacs. So because you might have pulmonary edema.
Okay, cool.
And also, like, if you're lying in a bed, you're deconditioned, you're likely at risk of infection as well.
Yeah,
So opening up those airways is
Fair
probably
enough.
good.
Anyway, for exams, just know the buzzword.
Cardiopulmonary.
Cardiopulmonary rehab. Refer to. Yeah. Okay. Okay. So now we've gone through non-pharm. We've gone through medical management of heart failure with reduced ejection fraction.
Mm-hmm.
Let's go to the interventional, and I'm talking about like surgical type things. So there are 4 main interventions. Does anyone have any idea?
Stents of some sort, if there's
Yep.
any obstruction
You're right.
of the arteries.
So overall, so you got coronary revascularization therapy.
Right.
So things like stenting, angioplasty, things
Would you
like
say
that.
coronary?
Revascularization.
Oh.
That's just kind of a broad kind of category.
Is that
encompassing
common?
all
Do
of
they
them.
get clots when
No,
they have
no.
heart failure?
The reason why you do that, because that could be the thing precipitating the heart failure, right?
So this intervention is for conditions that have led to the decompensation.
yeah, like coronary artery
Okay,
disease, which
okay.
is probably common in heart
Yeah,
failure,
yeah,
right?
Oh,
Yeah,
okay,
yeah.
I see. I
Yeah.
see.
Yeah. Okay.
So like
So
I see what you're
pacing
getting.
stuff as
Yeah,
well.
yeah.
Like a pacemaker if they need, if it's an
Wait.
arrhythmia or...
Yeah, not pacemaker. Oh, pacemaker may be indicated
Pacing.
if they got AF, but I was going to say
Cardioversion.
cardiac resynchronization therapy. So this is indicated in patients with heart failure who have a broad QRS complex, and sinus rhythm. Okay,
That's like branch block, right?
there are many causes of broad QRS, but anyway, cardiac resynchronization therapy is just one of those things you have to consider. Okay.
Sure.
Okay. The other electrical thing you may need to put in, I'll give you a hint. It's usually a patient heart failure needs is if their left ejection fraction is really low, or if they've got a history of things like ventricular tachycardia, ventricular fibrillation, which are life-threatening.
Like the defibrillator.
Yes.
Thing.
Defibrillator, right?
What's it called?
Inbuilt.
AUD or?
I just put down implantable cardiac defibrillator.
Okay.
ICD. It's called ICD.
Oh, it is ICD.
Yeah, ICD.
Cool.
Yeah.
Cool.
ICD, yeah.
Yeah. So
Yeah,
essentially, if they've got
yeah.
really severe heart failure
yeah.
It's a
and they've
pacemaker and a
maybe got a history
Yeah.
of VF, which can be life-threatening,
Yes.
you want to give them a
ICD,
defibrillator.
Yeah.
Okay? And the
So it's
last
just like an
one,
inbuilt defibrillator.
Oh, that's so cool.
Yeah.
What
the
the
last
heck?
one, the last intervention is when you've got severe heart failure and basically resistant symptoms, everything else is
transplant.
failing. Transplant.
Transplant.
which is pretty rare, I guess, right?
GG, what?
GG.
Just change your heart?
Okay, so can you recap all the 4 interventions?
Well, first thing I do is change my heart. Like a fucking transplant. Oh,
That's as you can imagine. That is the last
Where the hell I
option
get a
usually.
heart suddenly?
Don't say transplant first, because that's like the least. That's the
You're
least
just getting.
likely
I
one.
have to do 4. I can do that
Okay,
in any
okay.
order I
Yeah.
want. So I won't do transplant because that's just the sexy thing to do.
Most effective one, isn't it?
The second thing is the things that might cause the heart failure in the first place. So thinking of like atherosclerosis and coronary artery disease. So I'll do revascularization therapy. Third thing is that pacemaker with the ICD because you can you can get the heart to
But what patients need the defib? Not all patients with heart failure need the defibrillator.
when their ejection fraction's too low.
Yeah, as well as where they've got a history of
AF.
no
VT.
VT,
Ventricular tachycardia.
Oh.
because AF is common as hell, but it's more the VT aspect.
Oh, and that causes the wide QRS. That's another reason, right?
No, you're getting confused. The resynchronization therapy is just if they've got broad QRS complexes, whereas the cardiac defibrillator
Yeah.
is when they've got really bad ejection fraction and VT or history of VT.
Oh, okay.
Okay? So those 4
Yep.
things.
Sweet.
Okay. And do you guys want to know the 2 special case medications to
Give us
add to those 5?
Give us a clue.
I didn't want to.
No more, no
I didn't
more.
want to overwhelm
No
you.
more
No, no, no,
medications.
no, no,
No,
no,
no,
no,
no.
we're done.
Other medications.
If they
Just say them. Come on.
I just
Serious. I'm so curious
now,
now.
Dan. Okay, there are 2. Okay.
Sorry, guys.
Are they diuretics?
So,
hydrochlorothiazide.
okay. So that one of the
Must
2
be
special case
symptomatic.
medications, one of these are for patients with AF. Can anyone guess?
A blood thinner. Like
No.
Pixaban. No?
Yeah, I guess that's standard, but that's, I mean, like talking for the heart failure, not
Oh,
for
okay.
Digoxin.
digoxin.
Oh.
Yes.
Isn't that for symptoms though?
Yeah, but this is why I said the special case medication.
Yeah.
So if you got AF, the digoxin's usually helpful.
Yeah, yeah.
The other one is for patients where their heart rate is quite high, like above 70 on
That's
resting.
not
Are
And
these
high,
like
is
the
it?
sodium channel blockers?
No. Probably haven't heard of it. It's called ivabradine, which is a non-beta
Oh, of
blocker.
course. Of course.
A
Yeah.
non-beta blocker. So what is it?
Was it blocker? I didn't actually look it up. I just know it's a non-beta blocker.
It blocks everything else. It blocks
Who
everything else.
classified that? Okay, cool.
But anyway,
Thank you.
those are 2 other
Okay,
things.
that's it. That's all we need to know.
They're used rarely.
Not care
Okay,
anymore.
to
Don't
end
care
this
anymore.
episode, could someone recap to me the 5 prognostic medications you use for heart failure with reduced ejection fraction?
Okay.
5,
All right.
JT. Or who else? No,
Okay,
I bullied JT enough. Dan.
Look at Dan go.
Okay.
Dan.
So, ACE inhibitors or ARBs. Mind blank. Mineralocorticoid receptor antagonists. SGLT2 inhibitors such as empagliflozin. Nephrolithiazing
What's it called?
one.
What's it called?
You nearly there?
We're not
Entresto?
interested.
Entresto?
Interested.
Interesting.
Entresto.
Entresto.
Yeah.
Beta blockers. Sorry.
Yeah.
And I probably should have said that differently. ACE inhibitors, beta blockers, because they're...
You know, I would actually be so disappointed if you guys didn't remember these 5 medications.
I remember. I'll remember it forever now.
And the extra ones, a fucking non-beta blocker and digoxin.
Yeah. Simples. What?
Cool.
Okay, Dad, what is stressing you out right now?
I can't imagine saying to a consultant, a non-beta blocker.
Don't say it then.
I'm not going to.
Don't say you don't
I'm
remember.
going to say I don't know.
No, you say non-beta blocker rate control. That's what you say.
Mm.
That's fancy because you don't want to give them too many beta blockers.
Yeah.
But that's why I left it to the last. It was
No, good.
No, it's
spicy.
good, it's
out.
fine.
That's low yield. That's
Exactly.
It's so low yield.
Do you know what's high yield? 5 prognostic medication.
There's 3. You don't need the extra 2, do you?
Intresto.
Yeah.
Is it Intresto or Entresto?
Entresto.
E-N.
E-N-T-R-E-S-T-O.
Maybe getting wrong
Yeah,
there.
got entrust ourselves to this. Okay. Cool.
And the 4.
Surgical interventions.
Oh, yeah. JT already did it.
Yeah, those. You know, if you just remember medication, you'll be fine.
Transplant.
Yeah.
If all these 5 meds don't work, just new heart.
Yeah, just. But anyway, thank you all for listening. Hope you have all retained some first principles and at least remember 5 medications for heart failure. I hope to see you guys next week. Cheers. Bye.
Thank you.
Cheers.
So, my monkey brain and the monkey brains of all these medical students can remember 5 simple medications.
Thanks for listening, guys. If you liked this episode, feel free to check out the rest of our episodes available on Spotify. Leave us a review and a like. And don't forget to check out all the other resources, including Anki decks of each of the conditions we talk about on the podcast, available on the 1PM Notion website. Thank you.